Good morning.
Good morning.
All right, today we're going to pick up where we left off in chapter 22, and then hopefully tomorrow start chapter 23. And then, of course, we're getting down to the wire a little bit here. So next Thursday, as we know, is our last day. So yesterday, we left off at this inspiration, expiration. And we were talking about how we're going to have neurons that get stimulated. We're going to have in that medulla, in that region of the brain, we're going to have a respiratory center. We talked about having the dorsal and the ventral respiratory group, and how we have the innervation through that phrenic nerve into the diaphragm. And then we have innervation into those intercostal muscles. And we also mentioned, do you guys remember the Herring-Brewer effect, which was to help, make sure we don't over-inflate the lungs. And then when that happens, there's neurons that are going to send information after we inflate the lungs. Those are going to actually be inhibiting neurons. So after we start the inspiration and we begin to have those stretch receptors send their information, it's going to be inhibitory, and it's going to help us stop inspiration so that we can then begin to exhale out the air. So today we're going to pick up at the point where we are looking at, well, there's a couple of things we're going to look at today. We're going to look at what can create resistance when we breathe, basically the movement of that airflow. And then we're going to begin to look at gas exchange. So gas exchange in the lungs versus the gas exchange at the tissue level. One of the things that becomes important when we breathe, how compliant is this system going to be? When we breathe in and we breathe out, first of all, we're going to breathe in and breathe out based upon internal pressures within the thoracic cavity, and then external pressures that are around us. One of the things that I mentioned yesterday is we look at this movement of air based at sea level. All right? Anything that moves us from sea level actually affects the composition and the pressures of the air that are around us. When we are breathing, one thing that we want is to make sure that that airflow is moving nicely, moving correctly. You remember at the beginning of the chapter, I asked the question that have you ever felt like you were struggling to breathe, and how long did it take for you to begin to panic? Okay, doesn't take very long. Okay, only a couple of seconds for us to actually begin to panic. So when we have the airflow, pressure is a determining factor. Pressure based upon what is the pressure inside that thoracic cavity, what is the pressure that's even inside of that alveolus, okay? What's the pressure that's around us? So pressure is one of the determining factors about the airflow. And when I say airflow, I'm referring to whether we're breathing in or we're breathing out. Okay, so either one. The second determining factor is resistance. So this movement of airflow. Anybody else see this as a duh statement? Okay? However, this is a very relevant statement. because there are going to be several things that give us resistance to the airflow. Resistance is governed by the diameter of those bronchioles and then pulmonary compliance. What is it that's controlling the diameter of the bronchioles? Our smooth muscle. And smooth muscle is innervated by the autonomic nervous system. Pulmonary compliance will be a factor associated with that. And then compliance, if we think about that term, compliance, what does it mean to be compliant or to comply? Huh? What? Huh? To like to agree. Okay? So to what extent is the agreement of the airflow going to be? So we have these terms right here. Bronchodilation, bronchoconstriction. Just like their name implies, one, the diameter of those bronchioles increases. One, it decreases. The compliance. What is the ease that those lungs, okay, and the thorax are going to expand? And I think all that breathing I did yesterday made me tired, you know, because I kept doing all that breathing in and breathing out and everything. Went home, man, wanted to take a nap, but I didn't get to. So anyway, you know, so remember how I tried to take in a really deep breath? All right. How easy can that be done? All y'all take a deep breath in with me. Do you feel like it was easily done? No? Charity? What's up? No? Now, one of the things is, for most part, we don't breathe right anyway. Okay? Even if you're a healthy individual, but that's another time. The greater the compliance, the easier the lungs and the thorax are going to expand. The lesser the compliance, the harder. Can you think of a medical condition that's rather common that would affect these factors? Cystic fibrosis, asthma. I heard some other stuff. Emphysema. Okay. Some of these are more common than others. I'm going to use the example of emphysema because I just had a lady that I know get diagnosed with it. All right. And what happens with people who suffer from emphysema?
They hold too much CO2, they can't expel it.
Okay, you got a little technical on me there. So, all right, they're having trouble with those CO2 levels, okay? But physically, what do we see happen with people who might suffer from emphysema? Do what, man? Okay, they might have to struggle to get a breath in, okay? They might even have to struggle to get a breath out. Do you happen to know what goes wrong with someone who gets diagnosed or suffers from emphysema?
The bronchioles die.
The what?
The bronchioles or the alveoli die.
All right, let's get it down to the level where we're going to have the air exchange, okay? Now, do you guys remember at that point where we got all the little grapes and everything? Okay, we have the little membrane, all right? Then we got the blood capillary, all right? So, when someone is suffering from emphysema, what's going to happen is emphysema attacks and causes problems with the elasticity of the tissues. And then the other thing that begins to happen, we begin to break down this separation. All right? So where I had 2 grapes, it's going to now become 1. What could you see as being a problem with that?
Surface area.
It's going to affect our surface area, and if I affect my surface area, I'm going to affect the ability of the gases to move across that membrane. So it becomes a problem with the elastic recoil, and basically what will take place is that it makes expansion actually easier for the person, but just because it made expansion easier, what it's doing to the other tissues, this result in a higher than normal compliance, because it's affecting that surface area, they're not getting the same exchange of gases. So they might be taking in the oxygen, but it's not getting across the membrane. So it makes them feel that they are suffocating. And a lot of times they have to be, they have to have the oxygen and that sort of thing, move around with the tank.
Fluids also prevent the the gas exchange as well.
Right, it's going to prevent that gas exchange. So because we're affecting that surface area, the gas exchange is not as efficient as it should be. So I just used emphysema because it's one that, I'm currently, having to deal with. So resistance to the airflow, anything that's going to cause the lungs to have any type of an obstructive disorder is going to begin to affect these factors for the airflow. When we affect the factors of the airflow, we're going to affect our alveolar ventilation. Now, that's the point that we have to be at, because this is the point that the gas exchange occurs. So alveolar ventilation. What is going to be our volume of air that's available for the gas exchange per minute? And this can be measured. How do I know that it can be measured? Because they do respiratory tests, right? Okay.
Is that like when you blow, like after you've had surgery for a while, they're like,
Yep,
you gotta
get you
keep
to
trying
blow into
that
that thing,
out?
trying to move that, and they want that ball to move higher and higher. Yep. So when we talk about ventilation, what we're going to say, in the lungs, in this respiratory system, we're going to have what's termed dead space. Because as we breathe in and as we breathe out, okay, this is the areas of the respiratory system that no gas exchange is going to occur. And those spaces are either going to be termed an anatomical dead space or a physiological dead space.